So as we continue with this discussion from last week, the first slide that we left off was with on tissue blood partition coefficients. This is something that's actually very useful. Okay, these are the values that you end up seeing in different books. They actually mean something, though. Okay, they're just not in just numbers. They're indicating to you how much the gas will transfer into that tissue compartment. The more that gas will go into a certain compartment, the more the effect it has on that tissue. Okay? If you're looking at the blood-muscle partition coefficient or the muscle-blood partition coefficient, the higher the number, the higher the muscle relaxation that medication will have. So if you look at halothane, halothane has one of the highest numbers, which is around 3.4. And halothane, when you use it clinically, is actually very potent. And it causes extensive muscle relaxation on these individuals. The other number you'll see like sevoflurane is also a very potent muscle relaxant. Not only is it in skeletal muscle, but it also is a smooth muscle relaxant. And when we talk about as being a bronchodilator, it makes it a very potent bronchodilator as well. The other agents like desflurane does have effects as well, but as you can see, nitrous, it's almost a 1-to-1 ratio, so it doesn't have much of an effect at all. So having these tissue blood gas coefficients are pretty helpful in indicating to you how effective that medication will be in that tissue plane. Now, if you see a person have a lot of fat to blood transfer, fat doesn't really have any activity. It's mostly storage. So the problem with that is if you have a big, large amount of transfer of the gas into the fat, it's like filling up a vaporizer. So when you shut off the medication, that vaporizer now is a fat. And now it's going to begin to let the gas come out slowly and keep that person asleep or at least partially affected by the gas. If you look at ether, ether has a huge value, which is not even on here. It's like in the 160 to 180 range. So in the old days, when you shut off the gas, you could shut it off, if it was a 6-hour case, you could shut it off an hour before the case was finished, because you know it would take 2 to 3 hours before the person would wake up. And so it would be a long time for the stuff to come off. As the agents became more and more insoluble, which as you see, desflurane is very insoluble in fat, over here, 27.2, it leads to a much more rapid, crisp awakening. If you look at nitrous oxide, it has the lowest value of all, of 2.3. So, and if you think about it, it kind of makes sense why the dentists use it. The most common anesthetic outside of the operating room still remains nitrous oxide. They use it, the dentists use it all the time. And it makes you wonder, okay, if you have dental patients coming in, does the dentist tell you before he does a dental procedure to you, don't eat? Never. I've never had a dentist tell me that. Okay, and especially if they're going to apply nitrous oxide, they don't tell you to be NPO. So where's their nausea vomiting rate if nitrous oxide is such a nauseous agent? Think about that. Okay, it's something that we're using constantly. They're using constantly, and they're using it as an outpatient basis. These people go home after they're done. Why are they using it to them to go home? Why don't they use desflurane, because it's such a better agent, right? It's just fast off. It doesn't stay in the fat. And their nausea and vomiting rate is almost zero. The reason they have almost a zero nausea and vomiting rate is because they don't use any narcotics. They're injecting you with local anesthetic, and then they're just stunning you with nitrous. And then people don't wake up with any nausea. Okay? It's a synergistic effects most likely with the nitrous oxide plus the opiates that really give you a problem. But we'll go on we'll talk about that later. Now what you see here is if you see the tissue blood partition coefficient that's greater, the longer the time for the equilibration in that tissue to take place, the more saturation of the tissue takes place over time, and basically acts as a site of storage for the anesthetic, and acts as eventually as the if you do it long enough, it begins to affect your emergence. Like I told you, the greater the muscle blood number, the greater the muscle relaxation is. One of the things that I do want to sort of caution you is not only do you have to look at this number, but when numbers are similar, you have to look at the other number, which is potency. And isoflurane and sevoflurane, the numbers are pretty close together. Clinically, though, you see more muscle relaxation with isoflurane because it is more potent. Okay, so it's one of those kind of things like, which one's better? When you're talking about direct effects like bronchodilating effects, sevoflurane is better because it penetrates right into the tissue almost immediately and has a very rapid effect. Okay. So the greater the fat to blood number, it slows your speed of induction, it gets a huge storage space, and it leads to a much slower emergence. And if you're using agents that are very fat soluble, one of the big problems that you have is that it'll store in the fat, and if you have somebody that is morbidly obese, the person will emerge really, really slow, and you sort of have to anticipate that ahead of time to shut off the agents a little bit sooner. This is what a blood gas partition coefficient will look like. I mean, the tissue to blood partition coefficient. If you see the number like this case is at 1.6. That means there's 1.6 parts of the gas going into the brain in comparison to the blood. If you look in the muscle, this is for SIVO. It has 2.9 parts for every 1 part that's in the blood. And if you look at the fat for this one, this is 44.9. That means you have 44 boxes full of this in comparison to 1 of the blood. So it gives you a visual now representation of where that gas is going. Imagine each one of these boxes as filling up your vaporizer. So the more these boxes are, the more residual gas you're going to have when you shut off the agent. And then that stuff is eventually going to all come back into the bloodstream for it to be gotten rid of. One thing about volatile anesthetics is very different than medications that you give IV, is that 99% of what you give has to come back out through the lungs. Very little of it is getting metabolized, which is a good thing. Okay? But you have to realize that the only way the person's going to get rid of this stuff is by breathing it out. So anything that impairs minute ventilation, no matter what it is, it's going to affect your emergence. The slower you make somebody breathe, then the slower the emergence is going to be. Now, can you overcome that? Yes, you can put them on a mechanical ventilator and breathe it off. And sometimes it's a really smart thing to do. But at other times when you want people to spontaneously breathe, you just have to have the understanding that if you see the person's minute ventilation drop off too much, it's going to take a lot longer to wake up. And I'll give you an example of how to figure that out. Now, the other number that you'll see talked about a lot is the oil blood partition coefficient. This is directly related to MAC. Okay? It's actually inversely related. So the larger the oil to blood partition coefficient is, the less potent the medication is. So the higher the number, the more potent the agent, and the lower the MAC will be. Okay, so if you look at halothane, halothane's MAC is a 0.75. So that's a pretty strong agent. But you can see the oil blood partition coefficient is actually fairly high at 224. That's one of the highest that we have. If you go down further, you can see that desflurane is actually very small oil to gas partition coefficient of 18.7. But look at the actual max strength of 6. So that's a very weak agent. It takes a lot more gas to have the same effect. So that's how you actually look at that. If you see, you can pretty much figure it out by doing some mathematics on it. It's basically following this. If you look at nitrous oxide, it's an example of what insoluble blood gas partition coefficient is 0.46. It's actually 35 times more soluble than nitrogen. And because that nitrous oxide will replace nitrogen wherever it's at. It'll push it back out. So what you'll see is nitrous oxide will go into air spaces in the body 34 times faster than nitrogen can leave. How fast it will transfer in is depending on how much compliant that tissue plane is at. If something is very compliant, then the nitrous oxide will go into it much more rapidly. An example would be pneumothorax. Okay? If you have a pneumothorax, the pneumothorax will double in 15 minutes when you use nitrous oxide. So it'll be pretty significant. If you already have a fairly large pneumothorax, you'll go into tension pneumothorax in a matter of 15 minutes. And that's not necessarily bad. It's just that you need to learn how to use it. The way I was trained in doing trauma anesthesia was I was told immediately put nitrous on as soon as you put the person to sleep. Everybody's going, why would you do that? If you have a pneumothorax, you're going to find out that you're going to get a tension here really quick. And that's exactly the point. You don't want to be 35 minutes into the case and then get a tension pneumothorax. When the surgeon's already getting into the belly, and now he's got to stop, re-prep the chest, and get into the chest. So it's better for you to know up front that you got a tension pneumothorax, or you got a pneumothorax. Because I can promise you, if you have a pneumothorax, put positive pressure ventilation, you will have a tension pneumothorax in a matter of a few minutes. Okay? But it's going to take 30 minutes usually. Might as well accelerate it so you can put the chest tube in and take care of it. Whereas the nitrous oxide is contraindicated is partly to this. Okay? The contraindications for using nitrous oxide is if a person has an ileus, a small bowel obstruction. Anything where the intestinal tract cannot move forward, then the intestines will get dilated with gas, and that's not a good thing. Now, some surgeons will tell you that they want nitrous to never be given to their patients. And they don't understand. If you do actually a study and say to people, okay, which time do I actually have nitrous oxide on or off? And they did that a survey on surgeons, and they randomized who was getting nitrous oxide and who wasn't. And the surgeons didn't know ahead of time. And you know what the percentage guess rate was? 50-50. So guess what? They can't tell. There's no way they know if nitrous oxide's on or not. Okay? So in a regular patient, nitrous oxide doesn't cause any problem for the GI tract. It's only when you have an ileus or small bowel obstruction or a colonic obstruction then you have to worry about it. Well, the other reason that you don't want to use nitrous oxide is if the person has pulmonary blebs. You may actually cause that to develop into a pneumothorax sometimes. Or the other place where you have to be also worried about is if the person's had a tympanoplasty, where they've actually had their tympanic membrane replaced by a graft. You don't want to put a nitrous oxide on because this graft will actually peel away. That's always a bad thing. Okay? Now, is it contraindicated in tubes that we put in little kids? Actually not. It's a great thing because when the surgeon's doing the procedure, the tympanic membrane actually gets tight for him, so he makes it cut. It's actually a better cut. So it actually helps the surgeon in that situation. And we don't just usually do one-sided PE tubes. We usually do both sides. So as soon as you open up the hole in tympanic membrane and put a tube in it, what happens to all the nitrous oxide that's inside there? It comes out, so it doesn't become a problem. Okay? It might be also a reason why people get nauseous at times because if you ask people what they feels like after they've given high percentage of nitrous oxide, is they feel that their sound is muffled. The tympanic membranes can't move as well because the pressure inside of them, the nitrous oxide, is actually tenting them out. And sometimes that makes people nauseous as well. That's why I would recommend, if you are going to give nitrous oxide, which is fine to do, you can use either 70% if you need it for increased depth, or you can drop it down to 50%. Now, the other benefit of it is that it also has a second gas effect, which we talked about last week. The actual magnitude of pressure or volume transfer of nitrous oxide really depends on the partial pressures of the nitrous oxide, the blood flow to the air-filled tissue, and the duration of the nitrous oxide. At no time will the nitrous oxide cause an endotracheal tube to burst. It can't happen. Will it tighten the endotracheal tube cuff? Yes. Should you decrease the cuff pressure over time? Yes, you should consider it. But will the cuff explode with nitrous oxide? Absolutely not. Can't happen. It doesn't have enough partial pressure difference to be able to do that. Okay? But you can see here, 75% nitrous oxide will double pneumothorax volume in 10 minutes. We were taught 50% at 10 minutes, 50% increase. So this is pretty significant. Air bubbles rapidly expand, which is also a concern if you have a situation where you have air bubbles in the system. And if you can see here, this is a nice picture of somebody with a bowel obstruction. You can see how big the intestinal tract has gotten. This person was giving nitrous oxide during the procedure. You can see now it's become very, very tight. So you really don't want to do that in patients with bowel obstructions. This is where the middle ear discussion is, where it may cause the membrane to rupture, but that's pretty rare. It does make the ear tube placements easier, and it increases nausea and vomiting it's been observed. Now, how bad is it? That's really questionable. Some people say at 50% it's negligible. At 70%, it increases it by 5%. Is that worth it to stop that medication? We'll talk about it the next hour. Maybe not. Okay, but you have to take that consideration in the patients that you're taking care of. If you are taking care of somebody who's had eye surgery, you really got to pay attention to ask them if they had any intraocular gas bubbles put in, which is sulfur hexafluoride is the usual gas that's injected in there. And what the gas bubble will do is it can stay up there in the eye up to 10 weeks. If you give that person nitrous oxide within those 10 weeks, then that eye will expand and will cause retinal artery compression and blindness. So you got to be really, really cautious. Yes? What it does is the nitrous oxide will now refill this gas bubble. The gas bubble is actually pretty small, not as big as this, but when you add the nitrous oxide, it gets as big as that. And then you'll have somebody wake up and they'll be blind. Pretty devastating complication. So you got to make sure, especially here in South Florida, where you have older people with retinal problems, you got to ask them if you had any retinal surgeries before. Okay, diffusion hypoxia is a theoretical concern. Have I ever seen it in my clinical practice of 20 years? And my answer is no, because every time I discontinue nitrous oxide, I always administer 100% oxygen. So I've never seen diffusion hypoxia, and I don't think I ever will. So it's a theoretical concern more than a real concern. It's because what can happen is if the nitrous oxide, once you discontinue it, it begins to wash out of the lungs pretty quickly. It can actually flood the alveoli and push away the alveolar oxygen so you don't get enough oxygen uptake. But that can be easily overcome by just providing that person with oxygen. Now, one of the things that I do is when I start letting people spontaneously breathe, is I don't want the lung to completely collapse. Some people will tell you just shut off the ventilator and just sort of sit there and watch it, or grab the bag and sort of squeeze gently. I personally think that's a kind of a bad way of doing it, because what ends up happening is within about 3 to 5 minutes you see the saturation begins to fall. And a lot of these people will get a lot of post-op atelectasis because your glottis normally will start closing down to try to keep the air inside your lungs. But when you put an endotracheal tube in somebody, the air has only one thing to do, which is go out. Okay? So what I do instead is I close my pop-off down to a 10 centimeters of water pressure and keeps the lung inflated. And just by having the flows of oxygen going through there, it just compresses the oxygen in, and the person can stay saturated for up to 10 or 15 minutes, and you don't see that effect. So I think it's beneficial. Now, my personal feeling about diffusion hypoxia is that it's way overwritten about. As long as you're providing that person oxygen, it's something you really don't have to worry about clinically. Okay. What about cardiac output and pulmonary blood flow? If you don't have cardiac output going through the lung, the exchange rate of your gas goes to zero. If you already have an anesthetic on board and the person goes into arrest on you, I don't care that you shut off the ventilator. Okay, I mean not the ventilator, but I don't care that you shut off the vaporizer. Is the anesthetic depth going to change at all? And the answer is no. The gas is not going to go anywhere. It's going to stay in the blood. It's going to stay in the tissues because it's got nowhere to go. The only place it's going to be, the only time it's going to start decreasing is as soon as you get the blood pressure back and cardiac output is going to go back to the pulmonary circulation. So once you get the gas in there, it's trapped until you start getting reperfusion. And so you don't want to get yourself in that position in the first place. Now, where I saw somebody do this by accident recently is by a technique was called overpressurization. They actually turned the dial all the way up. Okay? Well, that's okay if you want the gas to come on board real quick, but you know what? You never take your hand off that vaporizer if you do that, because you can kill somebody, and that's what they almost did. Okay? They turned around, started doing something else, and by the time they turned around, the blood pressure was 35. Well, then they turned the gas down. Is that 7% gas that's already on board going to go down at all? Now with the blood pressure of 30, it's not. Okay, so now you're going to persistently maintain that person, even though you've dialed it down and you shut it off, it's not coming off until you get that pressure back up. And you have to really overcome that. You better have lots of pressure to do that. So your cardiac output is really going to affect your absorption. Okay? The lower the cardiac output, what happens in that situation is that your alveolar concentration equilibrates very quickly with that low flow of blood that's going by. So because of that, the induction actually speeds up. So low cardiac outputs actually speed up your induction. It's kind of backwards. Okay? The way you have to think about it is induction speed depends on concentration inside the alveoli. Now, will it take a little bit of time to get to the brain? The answer is yes. But when it gets to the brain, it hits them with a big punch because the blood is super saturated with the gas. Okay, so it may take time for it to distribute, but when it hits them, they're going to go down like a rock. And that's what happens to people that have low cardiac output states and you do an inhalational induction. It seems like it takes a little bit forever, but all of a sudden they go like, wait, it happened. And then you look at your blood pressure, and what happened? The blood pressure went to nothing, like that. So, and that's because simply that you get better saturation of the tissue, of the actual alveoli, which then causes this gradient to even be faster. Now, if your cardiac output is high, on the other hand, your alveolar pressures will drop off quickly, because as the new blood comes by that basically has no gas in it, it sucks it out of the alveoli faster. So it takes a longer time for you to equilibrate the actual gas concentrations to the levels that you want at the alveolar, because it's being sumped away by the blood. So it can slow down your induction process in that sense. Now, the more soluble the anesthetics are, they are affected more by cardiac output, which kind of makes sense. If the agent is very insoluble, then it really doesn't really matter, and that's what we find. So things like desflurane and sevoflurane, which are more insoluble, they don't seem to be affected by low cardiac output states as much as things that are like isoflurane and halothane. Now, one of the things that you'll see is the volatile anesthetics all depress the cardiac output, and it can exert a positive feedback effect, leading to actually a more rapid induction once it starts kicking in. The distribution-wise, the higher the cardiac output in that sense, the faster it gets there. But if you're after asking, well, which one is it that's going to make a difference in putting that person to sleep? If we're using the very soluble agents, like a halothane, let's say, we're doing a vaporized induction in that individual, and they have a low cardiac output state, that more soluble agent now is going to really concentrate, and it may take a little bit longer to put them to sleep, but once it hits them, it's going to knock them down pretty quick. So as for the desflurane, you don't see that effect as much in a low cardiac output state, so in that sense, it's a little bit safer to use, and sevoflurane is actually a great agent to use because it's not pungent, and people seem to tolerate it better. Now, what happens if you have shunt? Okay. Now, shunt is great theoretically, but clinically, it's something you don't see as a problem most of the time. So that's what but theoretically, and that's why they tend to want to ask you these questions, it's a concern, but in clinical, can you really see the difference? And the answer is maybe in 30 or 15 second difference, but is that going to be clinically significant? My answer is that no, not really. And I put lots of kids to sleep with VSDs and ASDs. Never had a problem with them going to sleep with inhalational agents. Okay? But if you have a right to left shunt, what ends up happening is that you dilute out the anesthetic. What you're getting in that situation is that you're taking blood that has not gone through the lung, and now it goes to the left side of the heart, which then dilutes out the gas that's coming with the blood via the actual pulmonary veins. So when that diluting effect, it's supposed to slow down your induction because the concentration in the blood is decreasing. Now, the more soluble agent, the less impact the shunt seems to have, but the less soluble agents cannot upset the dilutional effect, and as a consequence, you may see more of an effect like in agents like sevoflurane in comparison to halothane. What about somebody who has a left to right shunt, like an AV fistula? Okay, in this situation, the returning blood actually has a higher concentration in the arterial side, and it offsets the dilutional effect of a right to left shunt, and usually, again, it's not something that clinically you have to worry about too much. You don't see the difference there. So shunts really don't make a difference clinically, is what I'm trying to show you here. Now, if you look at nitrous oxide and shunts, nitrous oxide is a very insoluble agent. Okay, you can see in this situation that under normal circumstances, the FA-FI curve for nitrous oxide equilibrates very rapidly, under 10 minutes. But you can see if somebody has a right to left shunt, okay, you get a significant dilutional effect, and you can see a significant decrease in the concentration that's able to achieve. Now, when you put the mixed shunt, which is you go from right to left shunt and add a left to right shunt, then it normalizes to a more higher area, but never gets back up to what it should be. Now, is that clinically significant? The person's still going to be asleep by that point, and it's still pretty quick, but it's something that just, again, is something to discuss about nitrous oxide and shunts. If you look at your alveolar to venous partial pressure differences, these reflect tissue uptake of the inhaled anesthetic. And what you're looking at is you're seeing how much gas is coming back. If you have a large amount of uptake by the tissue, what happens to the induction? It slows down, okay? Because the alveolar pressures are going to be continually pulled out. So the faster you get venous concentrations to go up, the faster the induction is going to be. The way you always have to think about induction velocity is think about what's happening in the alveoli. If the alveoli concentration stays high, that induction is going to go quick. If you can slow it down by pulling the gas out faster. So higher cardiac outputs will pull it off faster. Okay, making it more soluble will make it more difficult for you to keep the concentration in. If you have the venous concentration coming back as being low, it also will make the situation slow down as well. And that's what they're trying to show you here. So if the greater the difference, the greater the uptake by the tissue, and that limits your induction velocity. Tissue uptake is determined by tissue solubility. And then we talked about that a little bit ago. We talked about how tissue blood distribution, partition coefficient numbers are important. The tissue blood flow is dependent on where perfusion is taking place. The highly perfused tissue, like the brain, heart, and kidneys, account for about 10% of the body, but actually receive 75% of the cardiac output. So most of the medications are going to reach that. And one of the things that when we talk about propofol later on, I'm going to show you that even that the brain receives a large part of the cardiac output, you can actually see different portions of the brain receive blood at different rates. We'll talk about how, when we talk about the propofol, how it affects the cortex first, then it affects the brainstem by walking it down, then eventually it attaches to the spinal cord, and how that affects actually heart rate. What you also see is that it equilibrates more rapidly with your actual arterial content as well as your alveolar time content. And normally it takes only 3 time constants to reach equilibrium with the vessel-rich group. So it's pretty quick, okay? But it's not immediate. So the normal time you're looking at for most of these gases is anywhere between 5 to 15 minutes. The reason you have to know that is that when you change that dial, you have to expect that it's going to take you 5 to 15 minutes. If you change that dial and you expect the pressure to immediately change, then you're mistaken. You have to watch what happens over the next 15 minutes for you to be assured that you're at the right level of anesthetic that you want to be. If you start doing this rapid movement of your vaporizer back and forth, what you're going to do is you're going to what's called over control. If you're a pilot, you will cause that airplane to go into a yo-yo effect. The airplane starts going up and down, okay, because you're over moving the stick. Okay, that's the same thing when you're doing with the vaporizer. You're going up and down too much. Just go up a little bit and see what happens. If the pressure starts going down, back off a little bit. The pressure comes back up, then try to find where. The nice thing about it now is you had your vaporizer, but you also have an agent analyzer. It tells you where you're at. And you want to sort of find the happy medium between the 2 points, so now you can smooth out your anesthetic. Once you learn to do it, your anesthetic will become railroad tracks. The actual blood pressure will become stable throughout the whole procedure. If you're doing over-modulation, where you're doing too much, your pressure is going up and down, up and down, up and down. Part of the reason it could be that you're low in volume, or it's just simply that you're just not using the gases appropriately. It's one of the two. Now, the determinants of your actual brain concentration, okay, will be determined by the brain-blood partition coefficient and also by cerebral blood flow. Remember, that's normally high, and you should expect rapid effect most of the time, which is a good thing, that's what our endpoint is most of the time in anesthesia, to put people to sleep. And what you can see is that your arterial to your venous partial pressure difference will actually determine the saturation in the brain. If you're looking at your gas analyzer, what you can extrapolate from that is the expired value. The expired value that's coming out of the lung is your brain concentration. Not the inspired fraction, but the expired fraction. So if I have to tell you, well, where is your anesthetic depth, and you see that the number says 2.4, let's say we're using, the example is sevoflurane. We just put the sevoflurane on, and we've got the thing dialed up to 2.6, but the actual inspired concentration on your monitor says 2.4, but your exhaled concentration is 0.8, which is still early. And I've asked you, what MAC are you at? And the right answer is, I'm under half a MAC. Okay, because the MAC for Sevo is 2, so it's at 0.8. So that's the real value. It's not the 2.4. That's not the MAC value for that individual at the time, because that's not brain concentration. Brain concentration is what you care about. So when you monitor and when you put down your gas concentration, you're going to put down the exhaled fraction of your gas. That's what you're going to calculate your numbers off of. Okay? And that's already talked about. Okay. If you're starting to see that your arterial to venous partial pressure difference is small, that means you've reached the top of the FA-FI curve, where now the two lines meet. That means the tissue is pretty much saturated at that point. If you're talking about a very insoluble agent like nitrous oxide, the FA-FI curve almost always meet each other, and it's usually fairly quick. Nitrous oxide will hit the FA-FI curve together and have a very slight difference in around 10 minutes. If you're looking at desflurane, it's right around 10 minutes because it has the same blood gas partition coefficient. But if you look at Sevo, it could be 15 minutes. And if you're looking at ISO, it could be almost 20 to 25 minutes. And if you're using halothane, it could even be longer. So different agents will give you different values. But once you see that small difference, that means that tissue is concentrated in the brain, and that if that person's stable, that's where you want to stay. You've done the right part of your job. Okay, now, what happens to age? Age really affects the pharmacokinetics of the gases. Okay? What you see with age is you have a decrease in lean body mass. There's also an increase in body fat. When you increase the body fat, that increases your volume distribution and also may decrease your elimination phase of the gas. The other thing you'll see is that you have decreased hepatic blood flow as you age because your cardiac output falls, and your metabolism and elimination as a consequence are both decreased. You also have decreased pulmonary gas exchange, which makes elimination again more difficult. And you see overall the person's cardiac output is decreased as you get older. This leads to a decreased lung perfusion, which increases your uptake and more rapid absorption, but it does affect the distribution by decreasing the tissue perfusion, which sometimes will, so which one is a major effect, and that really depends. Most of the time clinically you can't differentiate what the real problem is, but sometimes you'll actually see that this is not the limiting factor, but once you have the low cardiac output state, it may take you a little bit longer to put that person to sleep, but when it does affect that individual, it's going to cause significant cardiovascular depression. So you've got to be a little bit careful that way. Elimination is decreased perfusion in the lungs, prolongs your emergence as well. And this is particularly a problem in patients with COPD. Patients that have VQ mismatches in their lungs can be really problematic in getting the inhalational agent out. And sometimes it takes a lot longer time. If you're seeing that your end-tidal CO2 curve is not flat like it should be, instead that plateau phase is starting to rise, that means you have a lot of wheezing taking place in the lung. Well, that means there's a lot of trapping behind that of gas. And if the gas can't come out of the alveoli through the bronchus and out to the air environment, it's just going to sit in the alveoli and get reabsorbed. And it's going to keep that person asleep. So people with bad COPD and asthma can be a real pain to emerge from. It also can be very difficult to put them to sleep. If you can't get the gas in the alveoli, it doesn't get absorbed through the bronchioles. So it can be a real issue. Okay? Metabolism, we'll talk about this next week. There's minimal metabolism for the new agents, which is good. Halothane has significant metabolism, and it may actually be what causes hepatotoxicity, although that's a little controversial. We do know that halothane will break apart over time and will cause bromide to be released, which may be hepatotoxic. And you can see the other things that it produces is trifluoroacetic acid and all this other stuff, and we'll talk about that next week. So I just want you to know that some agents, the older agents, tend to be metabolized more, especially halothane in the presence of light. It begins to break down, and it also has inside of it a preservative called thymol. And if you don't, and one of the bad things about thymol is it begins to gunk up your vaporizer. So some of these byproducts or some of the things that are put in there to prevent the medication from breaking down can actually be deleterious to your equipment. Your recovery from the anesthetic is what I'm going to talk about next. Okay, this is a very important concept, okay, because if you begin to understand that, you will really understand how to emerge somebody, how you wake somebody up. And it's actually one of the arts of the job. What I'm going to try to do is I'm going to try to take it out of the art range and put it more into the scientific range, so you can actually do this very quickly once you get into clinical. Most people tell you, well, you know, you sort of have to just guess, and it has nothing to do with guessing. It has to do with understanding of how gases come off. Just like we try to teach you how gases go in, a lot of times people don't teach you enough about how the gases come out. Now, to recover from a patient from an inhalational anesthetic, it is totally dependent on minute ventilation. The minute ventilation is respiratory rate times tidal volume. If minute ventilation goes up, the person emerges more rapidly. If minute ventilation falls, it takes longer to wake the person up. Simple, right? All right. Now, what can affect minute ventilation? Lots of things, but particularly narcotics. And you'll hear people tell you that narcotics slow down emergence. You'll even see that written in the books. It really bothers me that people say that, because what ends up happening is it induces a fear in the practitioner to not give narcotics at the end. It makes you believe that the narcotic is what's slowing down the emergence. And it's not true. The narcotic doesn't suppress the brain enough to not let you wake up. The narcotic is suppressing the brain to slow down your respiratory rate so the gas can't come off. That doesn't mean you shouldn't use it. It just means that you shouldn't drop the minute ventilation down to 1.5 liters per minute. You should try to maintain your respiratory rate so you're delivering, say for an adult, at least 3 liters per minute. That's where you want to be. That patient's going to be comfortable. That patient's going to wake up reliably. That patient's going to wake up with no pain. If you don't believe that, and you believe that everybody should be not given any narcotics at the end, then what you'll have is high minute ventilations. People are going to wake up really fast. They are. Congratulations. You woke up somebody really quick. The only thing is, don't let me be your patient. Because when you wake up like that, the first thing that happens when you pull out the tube, the screaming starts. And you can hear them all the way to the recovery room. Okay? That's a great anesthetic. Okay? That's not the way you want to deliver anesthesia. You want to deliver anesthesia so the person's comfortable and they emerge. You have less risk of NMI, less risk of a lot of things. So titrating the narcotics is really an important tool to do this. Okay? Now, the other thing that's important besides minute ventilation is the gas quality. How good is the gas in the sense of, is it insoluble or is it soluble? The more insoluble the agent, the more rapid it comes off. Versus the more soluble the agent is, the more it stays in the fat, more it stays in the blood, and it wants to stay there. So the longer it takes you to emerge. Now there's benefits to having a soluble gas. A soluble gas stays in you for a longer period of time, so as you emerge, it's gradual. Okay, that's the benefit of it. The downside to it is if you have somebody with a bad body habitus and you give them the soluble agents, then it never wants to come off. And now you're getting to the complications of delayed emergence. The recent problems we've been having is that we're using very insoluble agents. And people are waking up screaming and becoming confused and not understanding where they're at. And that's called delirium, emergence delirium. And that is because the agents are coming off so fast that if you don't have the pain controlled properly, they wake up hyperagitated. I never understood that until I had a spinal one day. And I understood what emergence delirium is a lot of times. Okay, we had a great spinal on somebody. They did a cystoscopy on the individual. This is not a general anesthetic. We just did it on a spinal. The guy was wide awake, talking to me at the end of the procedure. Nicest guy in the world. Fine. Go to recovery room. Guy's been fine. First 45 minutes, the guy's crisp, talkative, very fine. 47 minutes afterwards, I get called by the recovery room nurses. I rush back. And here is this guy completely whacked out. He's totally crazy. Not talking to me. He said, "What's wrong? What's wrong?" He won't talk to me, won't identify what the problem is. He is just completely delirious. Start scratching my head. It's like, what the heck happened here? We didn't give him any medication, so he started running through all the problems. So I said, you know what? Do me a favor. The nurses look at me, what? Just drop the Foley catheter down. I don't know. It's the only thing that the patient has in them. As soon as they put the Foley catheter was dropped down, the guy woke up, looked at me. Wow, that really hurt. What hurt? That catheter, I can feel it. It was really hurting me inside. What happened was the Foley catheter was inflated in his prostate. And it wasn't until the spinal wore off that all of a sudden the pain came on so fast that he got delirious. So delirium has to do with most likely pain. We know this to be true when we give the inhalational agents that are insoluble. They come off so fast that when we give the narcotics to these people, guess what? They don't get delirious, the emergence delirium as much. So it's most likely related to pain. Okay? And people will do this kind of crazy stuff where they cannot talk to you. And always remember one thing. If you're seeing that situation, you didn't add any medications, always go back and see what was done. And if you can relieve that, take it out. And check the bladder, because that's one thing I found out the hard way too. Now the blood gas partition coefficient, okay, if you look at the poorly soluble agents that come off that I talked to you about, okay, we didn't move on now. The duration of administration is the other important part. The duration. The longer the duration for the soluble agents that you give, the longer it's going to fill up the vaporizer tank in the fat. On the other hand, the insoluble agents are not so much of a problem. Okay? So you don't have that much of an effect. Does it still accumulate? Yes. But does it accumulate as much? No. Okay? So the longer the duration, the more fat saturation, the longer the emergence for soluble agents. Poorly soluble agents are not really affected as much. So what this shows you is the duration of minutes to recovery. Okay? If you look at this example, sevoflurane and desflurane are both what? These are insoluble agents, and so is the nitrous. Look how it actually changes your actual time for emergence with that. Does it increase over time? Yes. So there's a little bit of accumulation, but it's not as bad as the other agents. Look at isoflurane. Okay? If you give it more than 1 Mac hour, okay, then you can see that your you concentrate the effect, and it takes up to 40 minutes to start waking somebody up. Okay, so after 1 hour, isoflurane really begins to saturate in fat stores. Halothane, on the other hand, is a lot more soluble than isoflurane. You can see that it also accumulates in the fat a lot higher, and it takes a much longer time to wake somebody up with halothane. So why is this important to know? Because one of the things that I try to teach you, especially when you're using isoflurane, is the first agent that you want to shut off is fluorine. Then you leave your nitrous on. The nitrous on is actually predictably going to come off, versus if you're using fluorine for a long case, you want to shut that agent off a lot sooner than you expect. You can run them on just nitrous and they'll stay nice and asleep. What I want you to do is when you're recovering somebody or waking somebody up, is that you need to think of it as an airplane. The airplane analogy of how the glide path is very appropriate for the anesthetic. If I'm using a very insoluble agent, okay, it's basically like I'm flying a brick. That means as soon as that airplane stops having the engine turned on, it drops like a stone. The perfect example for the least soluble agent would be a shuttle. That thing literally falls out of the sky. On the other hand, if you have a glider, okay, which is a very soluble agent, it's going to take forever for this thing to fall down. So your glide path is very nice and easy. It takes a long time. So if you have something that's very, very soluble, then you got to shut it off a lot earlier. What you want to do is basically, if you're combining a unsoluble agent with a soluble agent, you want to shut off the soluble agent first and then shut off your insoluble agent later, so then you hit your landing site at the same time. You want both those agents to be at the level that the person can wake up. So that's the glider analogy. If you look at, you want to replace it with names, you can say isoflurane is the most soluble SIBO, nitrous, and desflurane. Now my issue with using desflurane as a brick is I don't like the brick of using that one last, because desflurane is very pungent. And I've gotten myself more into trouble with that agent if I use it as the last thing to shut off. So for that reason, I never shut off desflurane last. I use nitrous oxide to the end. I think it's too fast of a descent for most people, and they get into bronchospasm and all sorts of trouble. So when I combine these two agents, desflurane and nitrous, then I shut off my desflurane still first because of the pungency issue. If you straight just out of the book, you would say, well, desflurane can be shut off last. And the answer is yes, if it was just as smooth as nitrous. You can inhale nitrous oxide, you could put it in a room, and people wouldn't even know you're injecting nitrous oxide in the room. They would have no clue you're doing it. Okay? And that can happen to you. I've seen it happen to me. I had one case where I was like dizzy the whole case. And found out later that the guy before me had left the nitrous on the case, and we were just doing a MAC case, and I wasn't paying attention to the lines, and we were just inhaling nitrous oxide in the room the whole 3 or 4 hours. I was going, wow, I don't feel good. Okay, so these agents can affect you when you're working in there. So what happens if you shut off all of your agents? If you're shutting off your isoflurane nitrous at the same time, what ends up happening is the nitrous oxide falls much more rapidly, and now this person is now. The reason that they're not waking up is that the nitrous oxide is gone, but the isoflurane is still hanging about you. So what you really should do is that you should shut off the isoflurane first, and then shut off the nitrous oxide following that. Okay? So always shut off your more soluble agent first, and then the least soluble agent next. Now what I'm going to talk to you about next is what's called time units. Time units are required for the actual alveolar pressure to drop by 50%. And this is the time that's dependent on how much alveolar gas must be ventilated to reach a decrease of 50%. This is an actual value. Okay, so this is actually something useful that's scientifically based, so you can emerge something very, very quickly. And it's also dependent on alveolar ventilation, not on overall ventilation. Remember, dead space ventilation is a big component sometimes, and if you increase the dead space ventilation, what's going to happen to your emergence? It's going to decrease. That's right. Okay? So if you have a lot of dead space problems, then you've got a big issue with emerging somebody. The less soluble agent, the less the volume is needed to clear the lung. Yes, that's true. And the time unit can be used on how much gas must be moved in liters. That's how I use it. I have a concept, and I'm going to teach you now, that you will think of gas not on just partial pressures, but you'll begin to think of them as how many liters do I have to move to get this gas to be reduced by 50%. Okay, so let's walk it through it. What I want you to do is, this is what's called an elimination half-time. And the elimination half-time indicates to you that when I stop an agent in a certain amount of time, which is a fixed amount of time, I'm going to reduce the concentration of that agent by 50%. So what you'll see over time is that this takes at least 3 time units before you can get to sub-anesthetic levels. So sub-therapeutic levels. If the first number is 50%, okay, that means if I'm at 50% nitrous oxide, then the first time scale of 50% decrease, I'm going to go down from 50% down to 25%. If I wait the next time unit, okay, it's going to take me to go from 25% nitrous oxide to 50% of that, which is going to be 12.5. So now you've gone down by 75% total. And if you do another 50%, now it's going to go from 25 down to 12.5 down to 6.5, and it's going to take another time unit. And by that point, most people are awake. That's where your cutoff tends to be, right about 3 time units away. Now, again, that's theoretical, and how do I use this, Dr. Nolan? It's like, how is that useful to me? I know that these are time units, and I know that 1 time unit is a 50% decrease every time. So how do I apply this clinically? And the answer is, you have to understand the gas, and you look at how many liters it takes to get the gas off. The more insoluble the agent is, the less minute ventilation it takes to blow off that gas. If you look at desferrane, which is a little bit more insoluble than nitrous oxide, it takes around 8.5 liters of minute ventilation to take off 1 time unit, or a 50% decrease. Nitrous oxide is going to take me 9 liters. And if you look at SIVO, it's about 13.8 liters, and ISO is about 15 liters to 29 liters, depending on how context sensitive it is. If I have this gas on for long periods of time, look what happened to the concentration. It doubled, because it now is saturated in the fat. Now it's going to take me longer to blow that gas off. That's the gases that are soluble. But once you get below SIVO, which are all insoluble agents, then you have to take that into consideration for ISO. Now, the way to do the equation is actually fairly simple. You won't see this written down. This is something that I've just come up with and actually works in clinical. It's just take the blood gas value times 20, and that gives you the actual liters. Simple little math. Okay, so 20 times whatever your blood gas partition coefficient is. Now, here's a trick. Let's say I want to use nitrous oxide, and I'm coming close to the end. I've shut off my isoflurane. The isoflurane is almost down to subtherapeutic levels. And I'm going to do what's called surfing the curve, and I'm going to have somebody talk to you about it, which is a formal student. Okay, now he's working with a school, which is Mr. Mears. Okay, he'll come out and talk to you next week about this. And what we did was we titrate the narcotic at the end to make the person breathe around 3 liters per minute. And that's normal for an adult. So when you're breathing at 3 liters per minute, how much time does it take to remove 9 liters? 3 minutes. So you should expect a decrease of nitrous oxide by 50% every 3 minutes. Okay? And that's just what it does. Okay? If you look at the 3 liters per minute, and the 50% nitrous goes down to 25% nitrous in 3 minutes. The next 3 minutes, it's going to go down from 25% down to 12.5% nitrous in another 3 minutes. And then the next 3 minutes, it's going to go down from 12.5 to 6.25%, which is the person will be awake by that point. So you know when you shut off the nitrous oxide at 50%, it's going to take approximately 9 minutes to wake the patient up. Now, how is that useful? Let me tell you how useful this is. If this person is breathing, let's say, all of a sudden, if they're breathing double the speed, instead of breathing 3 liters per minute, now let's say that we didn't give them narcotics, and we let them breathe just with lots of pain. Their minute ventilation now goes up to 6 liters per minute. Okay? Then, to get to 9 liters, it's only going to take me 1.5 minutes. So my half time goes from 3 minutes down to 1.5 minutes. So that person will be emerging in approximately 4.5 minutes to wake up. See how powerful that is? You're no longer guessing. Now you know scientifically that that person is going to wake up based on minute ventilation in literally 4.5 minutes. The downside of that is now when you extubate them, they'll wake up fast, but they're going to be screaming. Let me show you the mistake you can make next. Let's say you screw up, okay, and you do this. Instead of giving this person a little bit of narcotic, you gave them too much. And you make the minute ventilation drop down to 1.5 liters per minute. It's going to take me now 6 minutes to basically exhale 9 liters. So you went from 3 liters per minute at breathing 3-minute half times. Now you're going to be at 6 minutes for every half time. So instead of waking up in 9 minutes, you're going to be waking up at 18 to 20 minutes. Is that surgeon going to be happy with you? Is anybody in the OR going to be happy with you extubating somebody 18 minutes after the procedure? And that's what the danger of giving narcotics at the end is. Now, does that mean that you shouldn't give narcotics? My answer to that is no. It's got to be balanced. Everything in medicine has its good sides and upsides. You've got to realize where you want to be. You want to be on the perfect glide slope. You want this guy to be around 3 liters per minute and fly the slope all the way down to wake the person up. You don't want to overdo it because then you're in trouble, or you don't want to underdo it and then you're in trouble as well. Either one's bad, so you want to land it the right way. It's like landing an airplane. You don't want to overshoot the runway or undershoot it. Either one's bad. Okay? So the same thing what you want to do when your emergence is going to be. Does this make sense to you guys? This is actually a really difficult concept. I teach this all the time, and it's really very hard for people to get this initially until they play with this. Now, the benefit of learning this method is that no matter what the agent that you use, if you learn what the blood gas partition coefficient is and you learn what the liters per minute that you got to blow off, okay, then you can actually predict when that person is going to be extubated. I shake students up all the time because they keep telling me, I don't know when the person is going to wake up. Pull out my stopwatch, and I go, okay, click. I said, we're going to wake up in 2 minutes and 30 seconds. And they look at me like, how do you do that? And I wake them up in 2 minutes and 30 seconds all the time. Or just I tell them exactly when they're going to wake up. If I have a problem like this, what do I tell the student to do? Oh, let me just sit here and just wait for 18 minutes. No. What are you going to do? You're going to put them back on mechanical ventilation and blow it off. Get it down, and then when you blow all the gas off, then the person will breathe faster. Because part of the respiratory suppression is also the inhalational agent. So at least when the time you blow it off and you get down to levels, and you just put them on 3 liters per minute, get them off, and they'll be extubated in 9 minutes. Now, will they be a little bit more groggy? Yes. They may get a little bit more hypercarbic? Yes. But they will wake up in 9 minutes if I put it at 3 liters per minute ventilation. Okay. Now, if you use a less soluble agent like desferrine, I'm almost done. I know I just want to get this finished so we can go on to the next subject. If you give the less soluble agents, then of course it goes more rapidly. Okay, it takes less time. If you look at this agent, when you stop desferrine, it's a 6% at acid and 50% at 3 liters per minute. But it's 8.5 minutes to really to get there instead of 9. So you have to take into consideration the agent that you're using. So these people will wake up in around 8.5 minutes to awaken, which is pretty good. If you're using the more soluble agents like isoflurane or sevoflurane, okay, this one's a sevoflurane example. Okay, what it actually takes is around 3.8 liters to half. So you can see the first halving is going to take a considerable amount of time, more like 4.6 minutes. So these people will take 13.8 minutes to wake up. So what should you do with Sevo? Shut it off early. Okay? That's what it means. Okay? Otherwise, you're going to be sitting for 14 minutes at least to wake the patient up. Okay? If you're using Forane, forget about it. Okay? It'll take up to 17 minutes to wake up. And if you've been sitting there doing the case for 3 or 4 hours, it could be as many as 30 to 40 minutes to wake the person up. So these agents you have to shut off early. And the good thing is, as long as you've got good minute ventilation, I literally will shut off the Forane and SIBO when the surgeon is starting to close the muscle. I mean, that's how far out we are. We're 10 minutes away, but I know that the person's not going to wake up on me. Okay? And if they do wake up a little bit, I can give a little bit more. Give a little Diprovan if I have to. If I made a mistake. And we do make mistakes. That's part of our job. You're guessing. You're doing what's called an estimated guess based on the best principles that you have. Will you be always perfect? No. But it's really cool when the surgeon says, I'm done, tube comes out, same time. And the person opens their eyes and is pain-free. That is really cool. The surgeon looks at you like, wow. 30 seconds at extubation. The best I've had is 1 second after the surgeon said it was put the last clip in. I tapped the guy's head, he looked up at me, and tubal was tubed. Okay? That's perfect timing. Okay? So you can do it. And you will get so good at it if you do this technique that you will have a job for the rest of your life. Because they don't pay you to put people to sleep, believe it or not. It's easy to put anybody to sleep. I can get any Joe off the street to put somebody to sleep. It's waking up that matters. How smooth you wake people up is really what counts in this job. If you get rapid emergence, rapid extubations with comfortable patients, that's where your money's going to be at. Okay? If you're looking at isoform, look at what happens after an hour, 30-minute wake-up. So what can retard emergence? Rebreathing. And actually, I use rebreathing quite a bit. Rebreathing has a good aspects of it, too. If I drop my flow rates, the person will start rebreathing the gases coming out. And I'll show you a picture of that next hour. Or 2 hours from now. Okay? But rebreathing can actually be used if the surgeon's taking too long. You don't have to turn the agent back on. All you got to do is take your flow rates and drop them down. And the person will start rebreathing the gas and keep themselves asleep. I teach you guys that as well in clinical. Some other people will do that as well. So you can change your emergence velocity. I can actually change my stick on my airplane flying by changing my velocity. If I want that descent to go straight where I want to go and stay on glide path, I want to go full flow. If I want to retard the emergence and pull my stick back and let the airplane come back up, I drop the flow rates down and let the person rebreathe the gas. And it keeps them asleep. Okay? And the other thing you have to be worried about sometimes is some of the anesthetics would actually absorb into your circuit. I personally believe that there's a problem with humidifiers. Okay, I haven't proved it yet, but maybe I'll get one of you guys to do it one time when you're in the DNAP once we get that started. But I honestly think that we have some issues with gassing. The gas accumulates in this. And I've actually shown it to several students where the patient's not really waking up and the numbers are zeroed out because the actual analyzer is back here and it's saying that everything's fine and the person should be awake. And I looked at the student like, why isn't the person waking up? And say, I have no clue. I said, disconnect this sucker and see what happens. And sure enough, within 7 breaths, the person's wide awake. There must be something in there. I think it's getting trapped by the water vapor. Because once these things get really wet, this may actually act as a trap for the gas. So I've seen it enough times that I think you need to be concerned about it. And maybe some of the reasons that it's delaying your emergence.